think most of you know about pneumonia, but what we often don't appreciate is the consequences of pneumonia. And we all know about the short-term morbidity and mortality, but today I'm going to focus on long-term, which is not really that long, but anyway, medium-term as in more than 6 months, and the very long-term. So over the next 25 minutes, I'll just talk on 3 things. One is the context of pneumonia. 2 is the clinical consequences, and lastly, lung function and its trajectory with relation to pneumonia. So in a clinical context, it's so easy to say what's pneumonia, but when you actually trial and drill down, it's not actually that simple, because the diagnostic components of pneumonia depends on what specimens you use to diagnose it, what type of diagnostic facilities you have. The presence of a viral infection, for example, does not equate to causation. People talk about viral and viral bacterial infections, and a lot of studies focus on either viruses or bacteria, but there actually can be a mix. And then there's also the case definition of pneumonia. So pneumonia in various settings mean different things. So when you read about the studies of pneumonia, just be careful about what they actually mean. I'll give you an example. This is a study by Carey and O'Grady. So this was a randomized controlled trial we did on vitamin A and zinc, 147 kids. We looked at WHO endpoint consolidation for pneumonia, and we compared to a pediatric pulmonologist's definition of pneumonia on a chest X-ray. And we actually found a significant difference in the diagnosis up to 20%. Sorry, the mean was 20%. And I'll show you an example. So this is a WHO panel. It actually says no pneumonia, but all of you who are respiratory physicians will know there's right middle lobe pneumonia, and there's also left lower lobe pneumonia in this particular trial. So just be careful when you talk about pneumonia. So let us go to the clinical consequences, and I'll focus on biological plausibility, and then talk about the consequences related to the pathogens, acute diseases, and chronic lung diseases. So why is pneumonia important? So the biological plausibility is that you know that lung development occurs in utero, but unlike other organs, or unlike some other organs, a lot of growth occurs in the first few years of life. So that's the process of secondary alveolization. So we know that many things influence in utero development of the lung, but there are also important things that influence the postnatal development of the lungs, such as respiratory infections and ongoing inflammation. So nowadays, everyone knows that early life effects on later child into adulthood is no longer in doubt. In the past, people used to think that there's not a lot of effect, but there's epigenetics, and then there's genes. So the gene component is what you're born with, but there's also epigenetics, which is really, really important. So this picture is a picture of rats, and you can see the different colors, but they're all genetically identical. So it doesn't mean that it's just the genes that affect what you actually express, but the epigenetics are also very important, and these can alter depending on your life experiences and biological pathways and the gene expression. And a very clear-cut example, as shown in a lot of asthma studies now, is the environmental exposure on the TH skew in asthma. So what are the consequences of pneumonia based on pathogens? And remember, we are talking about long-term consequences. So remember the pathogens that we spoke about. So this is the PERCH study, and most of us think of it as bacteria. However, in the PERCH study, viruses were very important. As you can see, there were more viruses than bacteria. But if you look at Trevor Duke's editorial that accompanied it, in the PERCH study, 31% recruited actually had OVs. And funny enough, in most places, pneumococcal pneumonia is actually the most important pre-pneumococcal vaccination. And yet in the PERCH study, they actually found that countries with the lowest attributable fraction of pneumococcus occurred in the lowest PCV coverage. So there's something not quite right there, which really comes down to the concept of what is pneumonia in research components. And if you look at RSV as a consequence of pneumonia, I think most of you would know this paper published many years ago now. which people reported that it was associated with asthma. You can see a clear-cut odds ratio there when you've got RSV plus rhinovirus. However, if you cross the ocean and you look at the European-based study where they also used NPA specimens, but in this particular study, they used bacteria as well. They examined bacteria, not just viruses. And if you look at the odds ratio, which is unadjusted versus the adjusted odds ratio, you can see that RSV and rhinovirus no longer is significant for the development of asthma when they are age 7. So what it really shows is that is the number and not just the virus type that influences your outcomes. So let us move on to the next slide. I think most of you would know about the importance of adenovirus as well, and this paper is way back in 1963. If you draw on the more recent papers in South Africa, again, they showed that 29% developed persistent lung disease post-adenovirus. And most of you would have seen bronchoscopy like that, which is bronchiolitis obliterans, and that occurs in conditions post-measles, staph and mycoplasma, but it's non-specific chronic diseases that occurs post these infections, and bronchiectasis is also one of those components, and those are some of the references down there. What about acute pneumonia? What do you find after that? I'm not talking about stuff that Professor Colin Andrews is going to speak about. So I'm going to talk about radiological pneumonia and bronchiolitis in the long-term issue. This is a study that we did in Aboriginal Australians in Central Australia, and we followed a group of them with lobar pneumonia. The follow-up rate was 83.1%, and we followed up at the 12-month mark. And we actually found a very high incidence of chronic respiratory diseases, up to 25%. And you can see the diagnosis that we found there. But remember, this is Aboriginal kids. Obviously, depending on your setting, you're going to get different consequences. And this is just an example. This particular child came in with pneumonia there. 2 months later, we repeated the X-ray, and there was no pneumonia. This child was didn't have any bronchiectasis diagnosis pre-admission, and this is the child's CT scan. You can see clear-cut bronchiectasis in this particular child. So bronchiectasis is known to be a consequence of pneumonia. This is a case study, case control study done by Patricia Valerie, and she found that recurrent hospitalized pneumonia is a significant predictor, up to 15.2% in the odds ratio that's adjusted. And the more severe the pneumonia and the longer the hospital stay, the more likelihood you are to also be found to have pneumonia. The protective factors were breastfeeding, and the other risk factors were malnutrition and prematurity. This is Gabrielle McKellen's study. This is again in Aboriginal kids, where she randomized children to azithromycin for 3 weeks and followed them up. And what she found was that 20% of the kids had persistent symptoms at the 3 to 4 week mark, and of those children, a proportion of them had a CT scan, and those who had persistent cough had the elevated odds ratio of having bronchiectasis. If you turn the coin the other way around and look at chronic lung diseases, what is the antecedent to these as to how common is pneumonia found in these conditions? So bronchiectasis, as I mentioned, these are CT scans of a study that we do, and these are kids from New Zealand. It's pretty bad bronchiectasis. If you look at this particular slide from Jane Chalmers' paper, you can see there that post-infectious is a very, very high ascribed pathology or ascribed etiology of bronchiectasis in children as well as in adults. both in low-income countries as well as in high-income countries. If you look at PIBO, we all know that the ascribed etiology is usually infection. So if you look at chronic diseases, a lot of these kids had preceding pneumonia. So I'm going to come to the last component of my talk, which is really lung function. So why is it important? I'll talk about childhood effects, adult effects, and then trajectory. So the reason why lung function is really important is that more recently, or over the last 20 years anyway, people have found that the lung function, even in normal values, actually impacts on future health and disease. And I'll highlight this particular paper published a couple of years down. So this is a study on adults aged 35 to 70, and it was a really, really big study. It was a prospective study where they were followed up for 7.8 years. And they had an all-cause mortality in a cohort of 4.3%, and you can see the cardiovascular events there and the respiratory hospitalization events there. In this particular study, they defined FEV1 abnormality of a Z score than less than 0. And what they found with the odds ratio for all-cause mortality, you found a graded increase. So mild and moderate, you can see that the odds ratio was, the hazard ratio was elevated. And when it's severe, your hazard ratio was even higher. The key thing is that, remember that this is a Z score between 0 and -2 is actually in the clinically normal range. So even when your lung function is normal, you have increased mortality. And that's highlighted in this graph here, where you look at all-cause mortality. However, if you look at respiratory deaths and respiratory hospitalizations, it's not surprising that there's also a graded change according to your Z scores of your FEV1. But if you look at cardiovascular events, there's also a graded score. You can see for both cardiovascular deaths, myocardial infarction, and congestive heart failure. So, and no matter whether the country is high, medium, or low income, the findings were the same. And whether they were rural or urban settings, the findings were also the same. They then looked at population attributable risk of the impaired FEV1. Again, remembering that 0 to -2 is actually normal, and you can see the ratio there. But if you look at tobacco, hypertension, and all that, this attributable risk is actually higher than what you see in this. I'm not saying it's statistically higher, I'm just saying that it is higher. Okay, so it just shows the importance of trying to attain normal lung function in childhood. So what about the childhood effects? This is Karen Edmonds' systematic review. She's found a mix of obstructive and restrictive lung function. And again, she spoke about future lung disease and poorer lung health. And this is the graph that she produced, or meta-analysis that she produced, showing the different pathogens. But is it the chicken and the egg? When I first started doing research on this sort of stuff, they said you can't change anything. Why do you even bother? They were born with small lungs, and therefore they're more likely to get lung disease and pneumonia. So where's the evidence? So this is Heather Zar's Frankenstein cohort study. Diane Gray was the first author in this paper. They looked at lung function determinants in more than 500 kids. So they were tested at birth, and you can see there the things that affected the lung function. So the key thing is that they then went on to look at infants at year 1, and what they found was that low lung function was not a risk factor for the development of lower respiratory tract infection. They then looked at the effects of the lung function, controlling for other factors. They found that if you develop if you had an infection, you were more likely to have a higher respiratory rate, and the lung function was also affected. And the effect was greater if you had more severe pneumonia, which is similar to what we found, but the effect is also additive if you had low lung function to start. So this is a really important study, and I'm sure we'll get many more papers from Heather's group. So what about the long adulthood effects? There are many papers now. This is a very old paper showing that if you've got pneumonia or bronchitis, you drop your FEV1 and your FVC. And again, the effect is greater when you develop pneumonia at a younger age as opposed to at an older age. Again, bringing up the biological plausibility related to lung growth. So let's talk about the trajectory, because just to highlight the importance of this. I think you all know this now. This was proposed several years ago now. You're born with small lungs or big lungs. You grow as your lung volume or FEV1 improves, and then you get growth. And then later on, as you grow older, you can decline, or you can just have a normal decline or accelerated decline. So again, this is highlighted, but this is a longer x-axis in the for age, and you can see there again a similar pattern, but written by a different person in the New England Journal. So what I'd like to highlight here is Shamali Damaja's group in Melbourne, where you can see that she also looked at lung function trajectories. This was a prospective study of more than 1,000 over adults in the Tasmanian cohort. So these are the different trajectories which people have shown before in the two slides. But what they went on to show was you actually had two additional trajectories. So you have the orange one, where you can actually improve your lung function, and you have the blue one, where the decline actually does not happen when you're 50 years of age, but it actually declines much faster. So as I mentioned, this is a prospective study where they had lung function from 7 years of age, and then they followed them up to now they're actually in their 60s. So these two trajectories are really important because they are new, and this was published a few years ago now. If you look at the factors, again, bronchitis, i.e. chronic wet cough, inflammation, is a factor when you have accelerated decline, and it's also a dose response there, and you can see again pneumonia is also a factor with accelerated decline, and again here below average lung function. And to put things into perspective, she also found that asthma is a factor, and again the asthma component has been shown in previous studies. And again, smoking is a factor, but that's not really surprising. But what is new is this concept of bronchitis and pneumonia in the accelerated decline component. So lung health is the key to future health. Chronic productive cough, especially if you're less than 5, is the independent risk factor for cardiovascular events as impacts on lung function. And young adult lung function values is an independent predictor of all-cause mortality, okay, and particularly respiratory and cardiovascular disease. And adulthood lung function, a lot of it is set in childhood, but remember that you can actually alter some in childhood, shown by this orange graph or orange trajectory here. So biological plausibility, again, it's the respiratory infection and inflammation that inhibits this lung growth. So what can we do as clinicians? I think everybody knows about the Coase-Viscous cycle, but preceding that, there must be things that precede those things. I would anticipate that there's a degree of epithelial and endobronchial injury, and prior to that you get persistent infection and inflammation, atelectasis, and before that you're going to get acute respiratory infections, pneumonia, and all other triggers like pollution. Okay, so but I think you can actually alter this. This particular bit is really like protracted bacterial bronchitis when you get chronic wet cough. As the disease manifestation progresses, you're going to get chronic subacute lung disease. And then you get radiological bronchiectasis, which in initial phase is reversible, followed by a reversible component. But there are lots of things that we can do. There are modifiable factors, and in the clinical component, there are all these factors that we can also look at. So the key thing is trying to prevent this as clinicians. And again, we can make a difference in the kids' lungs. And this is a study by Andrew Calaro, who's doing his PhD with us, where we looked at Aboriginal kids that we saw in outreach. And you can see that if they were looked after by us in conjunction with their local doctors with asthma, after a 12-month period, you can see that there's a significant increase in their lung function, and similarly with bronchiectasis. So you can improve kids' lung function. So in summary, I hope I've shown you the long-term effects of childhood pneumonia. The studies are consistent across the decades, whether you look at individual follow-up or whether you look at cohort studies. If you look at chronic respiratory diseases, there's preceding pneumonia being an important etiological factor. It impacts on lung function, and very importantly, pneumonia also impacts on lung trajectory. And we can make a difference to these children's lives. I'll end there and take some questions.